Next up, we have the cornea. I always tell new technicians to think of the cornea like the watch glass of the eye. It is the dome on the outer front part of the eye. There are 5 layers to the cornea. The epithelium is the outermost layer towards the front. This is the layer that is most affected when we talk about things like dry eye, corneal ulcers, and corneal abrasions. The epithelial cells are amazing in that they can regenerate within 24 to 48 hours. So even when a patient has a corneal abrasion to the surface of the eye, those cells begin repairing themselves within a day or two. Underneath the epithelium, we have Bowman's layer, followed by the stroma. The stroma is the thickest layer of the cornea. If a patient has an injury to the cornea and it's a deep enough injury to affect the stroma doesn't heal like the epithelium, it scars. So unfortunately, if a patient sustains an injury across their central cornea and it's a deep injury affecting the stroma, they will have a central opacity that they will not be able to see through because the stroma has scarred. The 2 innermost layers of the cornea are Descemet's membrane and the endothelium. I also like to refer to the cornea as the first link on what I like to call the chain of vision, meaning when light comes into the eye, it must pass through 3 structures: the cornea first, the natural lens of the eye, and then it comes into focus on the macula. So the cornea is the first link on that chain of vision that allows us to see. Let's look at some corneal pathology. Corneal ulcers and corneal abrasions. The left-hand photographs are of corneal ulcers. One of the main causes of a corneal ulcer is contact lens overwear, meaning patients that wear their contact lenses either for too many hours a day or sleep in their contact lenses. Also, patients that swim in the lake or ocean or dirty water with contact lenses are more prone to developing corneal ulcers. Any disruption to the corneal epithelium could result in an ulcer. This is an active infection on the surface of the eye and must be treated promptly. Corneal ulcers can become devastating, so it's imperative to find out exactly what type of infection we're dealing with so we can treat it with the correct form of medication. Sometimes it's necessary to culture the ulcer and send it to pathology to determine the correct treatment regimen. The right-hand photo is of a corneal abrasion. This is a scratch to the surface of the eye. These are most evident when we put fluorescein dye into the eye and look through the slit lamp. One of the main causes of corneal abrasions that we worry about as technicians are when we perform applanation tonometry. There are many other things that can cause abrasions, however, like fingers to the eye, toys to the eye, both very common with patients that have children. Sometimes even twigs to the eye can cause an abrasion. Treatment for an abrasion typically involves an antibiotic drop and may require the use of a bandage contact lens to help with pain management while the abrasion is healing. Blood can collect in the vitreous gel in what's called a vitreous hemorrhage. This is very common with our diabetic patients because diabetic patients grow abnormal blood vessels in the retina that break open and bleed easily into the vitreous gel. Patients with a vitreous hemorrhage may notice a big new black spot in their vision that doesn't seem to move a whole lot. Doctors will instruct patients with a vitreous hemorrhage to sleep with the head elevated and monitor the condition. Typically, the blood will settle into the inferior vitreous before it absorbs back into the body. Sometimes, however, the blood doesn't reabsorb, and the vitreous hemorrhage continues and persists for some time. Then a doctor will perform a surgery called a pars plana vitrectomy, or PPV for short, where they remove the vitreous gel from the eye and replace it with a new solution. With dry macular degeneration, we all lose our retinal cells with age. In the dry form of macular degeneration, we often see what are called drusen. Think of drusen like a garbage disposal problem. They're waste deposits in the retina. Drusen can appear on their own and not be indicative of dry macular degeneration. But with dry macular degeneration, we tend to notice an increase in drusen with progression of the disease. Dry macular degeneration can be slow progressing or it could be faster progressing in patients, depending on their genes. With the dry form, we lose our central vision. Remember, the macula is responsible for our central vision. So we start to lose the central vision of the eye. Up until today, for dry macular degeneration, all we could do is recommend things like AREDS2 vitamins, green leafy vegetables, and not smoking, as they were all shown to slow the progression of dry macular degeneration. In February of 2023, a new drug called Syfovre was FDA approved. This is the first injectable drug for the treatment of dry macular degeneration with something called geographic atrophy. We'll have to wait and see how Syfovre works. But it is astonishing that in this day and age, we're now developing a new treatment for dry macular degeneration. This is only the beginning of hopefully what will be a brand new treatment regimen for a disease that we previously could only slow the progression of. Now we've reached the peripheral retina. We focused on the center with the macula. Now we're going to talk about the far periphery of the retina. This is described in quadrants or arcades and examined with the indirect ophthalmoscope. Let's look at some of the common pathologies of the peripheral retina.
There are three main ways that we deliver locally applied medications to our patients in the office. First are solutions. These do not blur the vision, but they have a short duration, so they require frequent instillation. Suspensions have two medications in the bottle, and you must shake the bottle to mix the medications before it's instilled. Ointments have a long exposure time to the eye, and they blur the vision. These are good for crying children because their tears will not dilute the ointment. Before instilling eye drops, wash your hands. Don't touch anything to the dropper tip. Have the patient tilt their head back and look up. Pull the lower eyelid down to form a pouch and then aim for the pouch. Injectable anesthetics have many side effects. They can cause low blood pressure. They can depress respirations. They can stimulate the nervous system, and they can depress the central nervous system. If your patient faints, you want to have the patient's head between their knees, lower than their heart. Have smelling salts available, loosen a tight collar if they have one, and make sure you stay with the patient for at least 20 to 30 minutes. Also, call for help. Let your doctor know that a patient has fainted. IV fluorescein is the most common cause of allergic responses in ophthalmology, but any medication can cause an allergic response. Typically, symptoms will appear within 20 to 30 minutes of exposure to the medication. The signs and symptoms of an allergic response are listed here.
The scribe is the assistant to the T. The scribe gathers all tools or equipment necessary for the patient exam. If the doctor's in the room with a patient and they need a tool or piece of equipment that's not there, guess who's going to get it? It's not the doctor, it's the scribe. So scribes need to know where all the tools and equipment are in the office so they can quickly go gather what is needed and bring it back to the doctor. Scribes are often the finder. You're finding the patient first of all and bringing them to the room. And when the patient comes back and wants their family, friends, or caregivers to come with them, you may have to go to the waiting room or out to the parking lot to find whoever they want to come back in for the exam. Scribes are the traffic director, or keeping the ducks in a row, I like to call it. Looking at the schedule, you're directing the doctor which room to go to next. You're expediting the clinic flow by telling them which patient may not take as long as the others. Seeing post-ops first, for example, before you would see a brand new patient, helps improve the clinic flow. Finally, being the assistant means being the peacekeeper. Delays happen in the ophthalmology clinic. It's known. We see emergencies, there's add-ons, maybe someone walked in that was scheduled and wasn't put on the schedule. So doctors typically run behind. It's up to the scribe to keep patients abreast of any delays in the schedule. I've always gone by, it's better to update them about the delay than let them sit and wonder what's going on. So if my doctor was running behind, I would kindly just announce to the waiting room, Dr. So-and-so is running a little behind. We've had some emergencies. We ask for your patience and apologize for the delay. Patients will be much happier if you give them an update ahead of time rather than place them in a room and not tell them of any delays. The observation specialist. As a scribe, you have to know the parts of the ophthalmic exam. When the doctor's looking at the anterior segment versus the posterior segment versus the peripheral retina, so you can be in the proper area of the chart to document the findings called out to you. As a scribe, it's super important to actually watch the exam. Many times a doctor will call out right eye and give you findings when they're actually looking at the patient's left eye. Doctors get backwards just like us, so always pay attention to what eye they're examining so you can properly notate your findings. Always anticipate your physician's needs. If you know that the patient's a narrow angle evaluation, have the gonio lens in the room with the solution on it, ready to go. If you're in the retina clinic and your doctor uses a 3-mirror lens on any patient with new flashes and floaters, have the 3-mirror lens on the desk ready to go. It may seem silly and only save seconds, but seconds add up throughout the day. So having this equipment on hand and ready to go could save you several minutes in the course of a day. One final thing is to always pay attention to patient positioning. If the patient is having trouble staying at the slit lamp or in the laser, you may need to help hold their head in place to help expedite the exam and allow the doctor to properly see the eye. During the anterior segment portion of the exam, the doctor is looking through the slit lamp without the use of any lenses. During this portion, you'll notate findings for lids and lashes, conjunctiva and sclera, iris, anterior chamber, and the lens. The doctor is examining the posterior segment when he or she is at the slit lamp and is using a 60 or 78 diopter lens. Typically at this point, they're only looking at the macula and optic nerve, although they may call out pathology for the vitreous and the vessels as well. Some doctors also prefer to do their peripheral exam at the slit lamp. Your clue to this will be if they start to call out your directions: up, down, left, right, up and left, down and left, up and right, and down and right. If the patient's at the slit lamp and the doctor is using the 60 or 78 diopter lens and calling out these directions, you will document findings in the periphery. Otherwise, it will be limited to macula, optic nerve, vitreous, and vessels. When the physician places the indirect ophthalmoscope on his or her head, they're using a 28 or a 20 diopter lens to look at the peripheral retina. That's also when they'll be calling out the directions: up, down, left, right, up and left, down and left, up and right, down and right. That way they're looking at the entire retina periphery. That's where you'll document any findings called out to you. in the peripheral section of the chart. There's an exam mnemonic called SOAP, meaning subjective, objective, assessment, and plan. Technicians on the workup side put the S in SOAP because they do the subjective portion, gathering information from the patient, building the patient's history and reason for visit. Scribes put the OPE in SOAP, so scribes are responsible for the objective part of the exam, notating all of the exam findings in the proper areas of the chart. The assessment are the list of diagnoses that the doctor forms based on the exam findings. And of course, the plan is the plan of action. What is the doctor going to do for each of those diagnoses to treat the patient? So the scribe is notating all three of these components of the exam. To educate and to consent, two tasks that are often put on the scribe. Scribes are allowed to answer patient questions within reason. The general rule of thumb is, if it's something the physician has already said to the patient, it is okay to answer patient questions and reiterate medical advice that has already been given to the patient. You can also educate the patient on their diseases to a degree. Most often than not, this means discussing use of things like the Amsler grid and how to use the eye drops or eye medications prescribed. Scribes are not allowed to give medical advice that has not been given or alter the medical advice that has already been given. If a patient asks the scribe's opinion on whether or not to proceed with a treatment, the scribe should stay neutral and defer any further questions to the physician. That will keep them well within their scope of practice. Consent forms often fall on the scribe as well. It's imperative for the scribe to guarantee that any and all consent forms are signed and on file before the procedure is completed. This includes consent forms for intraocular injections, lasers, and other in-office procedures. It is not advised to collect a consent after the fact. Always make sure you have your consent on file prior to the patient undergoing the procedure. If the patient has any questions about the procedure or their diagnoses that you cannot answer or that has not been dictated by the physician, have the physician return to the room to properly address these concerns with the patient. One role that the scribe definitely fulfills is that of the planner. The scribe's main function is to document all of the following into the medical record. The physician impression. This is the list of diagnoses that the physician has come up with based on the exam findings. The plan of treatment. This includes medications that have been prescribed, labs to be ordered, and any treatment modalities that the physician recommended, including lasers, injections, and/or surgery. Any and all patient and physician discussions should be notated in the medical record. Electronic medical record systems are great in that they include canned plan notes that help you put together a plan for each diagnosis. However, scribes should be cautious not to rely solely on these canned plan notes and expand from them further to make the medical record unique to each patient and each visit. Also documenting the plan includes when follow-up is indicated for each patient. Eye codes. They are unique in that ophthalmology is the only subspecialty that has their own set of codes. Ophthalmology codes are defined as an assessment of the visual system, meaning the eyes. These are the codes that start with 9-2. As you can see, for new patients, a comprehensive level code is 92004, while an intermediate level code is 92002. For established patients, the comprehensive level code is 92014, and the intermediate level code is 92012. The difference between comprehensive level and intermediate level usually involves dilation. If the patient has been dilated and a full ophthalmic exam has been completed, then it is appropriate to code the comprehensive level code. Intermediate codes are utilized for quicker follow-ups that do not require dilation, like pressure checks, cornea checks, and so on. E&M codes is short for Evaluation and Management Codes. These types of codes are used by all areas of medicine, meaning primary care doctors, endocrinologists, rheumatologists, and so on. Evaluation and management codes are different in that they're no longer history-based. They reflect more on medical decision-making and physician time with the patient. That's how you determine what level of E&M code to use. E&M codes will typically pay more than ophthalmology codes as well. These are the codes that begin with 99, and there are 4 levels, levels 2 through 5. For new patients, level 5 is 99205, level 4 is 99204, level 3 is 99203, and level 2 is 99202. For established patients, level 5 is 99215, level 4 is 99214, level 3 is 99213, and level 2 is 99212. What medical decision-making means is how many diagnoses did the physician have to address? Were there any new diagnoses? How significant are the diagnoses? And how many medical decisions did the physician have to make in order to treat the patient? Patient or physician time with patient is the face-to-face time that the doctor spent in the room with the patient. Many EMR systems are built to help you calculate the appropriate level of evaluation and management code to use. Let's talk about making that connection. When you're coding out diagnostic testing or procedures, it's important to make sure that the codes that you correlate with the testing code or the procedure code match the reason that it was done. For example, if you're billing out an OCT-RNFL, it should associate with the diagnosis that drove you to do the OCT-RNFL, most likely glaucoma suspect or some type of glaucoma or optic nerve pathology. OCT macula, there has to be some type of retinal diagnosis to go with the OCT macula, like macular degeneration, epiretinal membrane, or macular edema. For FAs, why did we order the FA? Why did we need to do it? Is it for a vein occlusion or is it for proliferative diabetic retinopathy? PRP laser, once again, why did we do it? Probably for proliferative diabetic retinopathy. We did a gag capsulotomy today. Why? Because the patient has posterior capsule opacification. Most EMR systems will automatically link these, but just double check to be sure that the correct diagnosis code was linked with the testing or procedure. Insurance companies also dictate what the appropriate frequency of tests is. For the OCT macula, patients can receive an OCT macula up to 4 times per year or every 4 weeks if they are receiving intravitreal injections. This means if you're billing an OCT macula at a greater frequency than 4 times per year, You should not be coding for it more than 4 times per year. The exception is a patient receiving injections for either macular degeneration, diabetic macular edema, vein occlusions. Any type of intravitreal injection patient can have an OCT every 4 weeks to assess the response to the treatment. For OCT RNFLs, the frequency is twice per year for early or moderate stage disease. That just goes to show that staging is super important. If you have the glaucoma coded as early or moderate stage, you can only code the OCT RNFL twice per year. For fundus photos and FAs, there's not really a guideline for the frequency, but you must have a clear documentation for the reason for the testing. Meaning, as the scribe, if the doctor is ordering a repeat fundus photo or FA today, document in the medical record next to the diagnosis that you're ordering the test for. Dr. Smith ordered FA today to determine if there is a recurrence of CNVM. That would be a great line of documentation illustrating the clear indication for the reason for the test. If I could insert a drum roll here, I would. A super scribe should be a good communicator. This is key on so many levels. A scribe must be vocal and cannot be afraid to ask questions of the physician or speak with patients. Those are 2 tasks that the scribe is entrusted with every single day. Scribes are constantly asking the doctor questions to make sure they have proper documentation, are notating the proper procedure, coding the chart out correctly, and so on. Scribes must also be able to talk with patients and communicate to them what the physician has already dictated or said to make it more clear, and also communicate to patients medications use, how to use the Amsler grid, when follow-up is indicated. So communication is very key in the scribe role. This one goes without saying. Scribes must be an effective listener. Listening is a crucial part of the scribing process. Scribes are constantly notating information into the medical record, and while doing so, they must continue to listen to the physician discussion with the patient to make sure they don't miss any crucial information that needs to be documented into the medical record. Empathy. This one is also huge. We recommend to administrators that are hiring new staff to look for this quality. Someone that is able to appropriately respond to patients. Sometimes we know that patients will overreact about diagnoses that we know aren't serious, like dry eyes or a subconjunctival hemorrhage. But it's important as technicians and scribes to put yourself in the patient's shoes. Patients aren't as well educated on eye diseases as we are, and they're frightened by these new diagnoses and may not understand that they're not as serious as they think. Show care, show compassion to the patient. Think about if that patient was your mother, your aunt, uncle, grandparent. How would you want them to be treated? Would you want someone to brush them off like it's nothing? Or would you want someone to show them the care and compassion that they deserve? So showing empathy towards patients is a huge attribute of a scribe.